Hi, my name is Gregory Vidal. I'm a breast medical oncologist at the West Cancer Center and Research Institute and the University of Tennessee Health Sciences Center. We are here today at ASCO 2026 discussing early breast cancer, and with me, other medical oncologist and breast surgeon, and I'll allow you to introduce yourselves.
Sounds great. Thank you, Greg. My name is Pooja Advani. I'm a medical oncologist specializing in breast cancer at Mayo Clinic in Jacksonville, and I also serve as the director of the Multidisciplinary Breast Center there.
Thank you.
Thank you, Greg. My name is Tari King. I'm a breast surgeon. I'm the chief of the Division of Breast Surgery at Emory University Winship Cancer Institute, and also the chief surgical officer of the Cancer Service Line.
All right, so let's get into it. So we're going to discuss two trials, important trials, DB05 and DB11. Both of those were recently approved by the FDA. Can you give me, in your own words, the shot of what either of those trials are?
Yeah, that sounds great, Greg. I felt like we had a whole bunch of data that was offloaded onto us with simultaneous approvals of both DB11 and DB05. So I think DB11, so it's a neoadjuvant study, a phase 3 study. It involved a high-risk patient population, so one that had, clinical T3, T4 disease and any lymph node status, and also patients that were lymph node positive. So truly a high-risk patient population here. And initially, they had 3 treatment arms, so T-DXd alone for 8 cycles. The second arm was 4 cycles of T-DXd, followed by 4 cycles of THP, where the taxane, was the weekly paclitaxel. And then finally, they had 4 cycles of dose-dense AC, followed by 4 cycles of THP. And I think subsequently, because of futility, the monotherapy arm was close to accrual, and the readout was the primary endpoint was the pathologic complete response rate. And I have to say that this is one study where we've had the most phenomenal pathologic complete response rate of about 67.3% with the group that received T-DXd 4 cycles, followed by 4 cycles of THP. In the comparator group, which is AC, it was 56.3%. The secondary endpoint, which is the event-free survival, is still not mature. It's only 4.5% data maturity. But I think this is a phenomenal pathologic complete response rate that we've seen. And I think what I would like to highlight is that in their baseline characteristics, 80% of patients had lymph node positive disease and 70% were ER positive. And we know historically these tend to have a lower PCR rate. So despite enriching for a higher risk, difficult to obtain PCR, they had phenomenal outcomes.
Thank you very much. In context, also what was very important in all of this data set is when you look at the hormone receptor positive patient population, we tend to think of that population as having a lower PCR rate. The PCR rate was pretty impressive. Close to 60% of those patients had a PCR rate. We usually expect like a 35% PCR rate for that population. Is that going to impact your choice of regimen? In fact, let me ask the question differently. Are you instituting DB11?
Absolutely. I think it has been transformational for the landscape. And I do want my patients, particularly the high-risk patients, to have the opportunity to have good outcomes at surgery. And I think what I was also impressed is, by the data that was presented recently at ESMO Breast by Dr. Pusai, is that, the use of T-DXd resulted in reduction in the proportion of patients who had RCB2 disease and a higher proportion of patients in RCB0 and 1 disease. And I think that's really impactful. If we look at the data from Keynote 522 and sort of the way the journey played out, when we saw initially the shift in the dynamics of RCB, we did see some good results as far as event-free survival and overall survival. And recognizing that this study was not necessarily powered for disease-free survival, I think it is going to result in something positive as we see the shift in the dynamics between RCB0 and 1 and RCB2.
Thank you very much. And we'll stay on DB11 a little bit. I'm going to get you in surgeon's perspective. How important is it for you when you see a patient? Because you often see the patient before we do and need to make the decision about when you send a patient for quote unquote neoadjuvant therapy versus take to surgery. How important to you is data like this, where you almost 70% of patients, when you give them chemotherapy, you have nothing, you find no disease at surgery?
Yeah, no, it's very impactful data. I completely agree that I think it is changing the landscape for how we think about our choices. I've always been very enthusiastic about preoperative therapy, particularly in the HER2 positive population, again, where we know we see high rates of PCR, and it's really important for me as a surgeon to really be able to articulate to my patients that really the goal of preoperative therapy is not just to make my surgery easier. The goal is to really help us understand their response to treatment and tailor their adjuvant therapy for improved long-term outcomes, right? So while as a surgeon, while we get that secondary bonus of downstaging tumors or achieving PCR in the axilla so we don't have to dissect, it really is important to present the neoadjuvant concept as truly an important opportunity to tailor therapy, whether that's escalating therapy or whether that's de-escalating therapy. And so
surgeons at my institutions are doing a lot of oncoplastics now. Does the response to treatment impact that? I know it does impact the axilla as you discussed. Could you talk a little bit more about when you go in the axilla versus not and how this therapy will impact that?
Sure. Well, yes, there's been a lot of attention to de-escalation axillary surgery. Certainly with these high PCR rates, we know that we can convert people from pathologically node positive to pathologically node negative. We can stage the axilla with sentinel node biopsy, and then we can omit axillary dissection if they've achieved a nodal PCR. The breast, our ability to downstage our surgery, if you will, in the breast or de-escalate breast surgery is a little bit more complicated because there's a lot of patient preference that comes into the decision about the management of the breast. So while we, again, really appreciate these higher rates of PCR, that doesn't always translate into more breast conservation, for example. Genetic testing is important, patient preferences are important. But I do think that, again, with this continued improvement in PCR rates, that I hope that we'll be able to sort of challenge some of the traditional paradigms. So, for example, in patients who have multicentric disease or diffuse multifocal disease in the breast, we as local therapists have said, well, you need a mastectomy regardless of your response. But again, if we have these incredible rates of PCR, if our imaging improves along with our systemic therapy so we can better calibrate what that response is, then perhaps for those women who are motivated to achieve breast preservation, perhaps some of our old rules about when we should or shouldn't offer it can be, transformed again by the transformational rates of PCR that we're seeing.
So thank you very much. And staying in the early setting, local management. Also, I want to touch a little bit about ctDNA.
Yes. No conversation is complete.
No conversation is complete without it. We haven't seen any data on ctDNA from either of those yet, and I'm hoping we'll see some MRD assays. For either of you, how do you think a technology like this can help even with de-escalation, with patients' anxiety, with understanding who's going to get a PCR before or after? Do you want to take any of that?
Sure. I love that you throw the controversial ones at the medical oncologist. But so, I mean, I think ctDNA is not going anywhere. I think we've learned to embrace it and, individualize the conversation around it with our patients. There's plenty of data to suggest its prognostic benefit, really not a lot of data for predictive benefit. But I do think as we talk about personalized management, even in the neoadjuvant setting, ctDNA could be a valuable tool. As we talk about DB11, I think some of the thing that has been considered is in a subset of patients, could you consider doing THP initially and then seeing their response? Could ctDNA be one of those sort of points or decision, crossroads, and then you can escalate to the 4 cycles of, give them 4 cycles of T-DXd if they're not responding adequately via ctDNA. So I think it's definitely going to be well integrated. We don't have that kind of data to comment right away, but I do have individualized conversations with patients on escalation and de-escalation. If they're not tolerating it well and they're clearing their ctDNA, that's also an important thing to consider.
How are you surgeons thinking about ctDNA?
Well, again, I think it's a really interesting opportunity for us to have another piece of information that helps us to assess response, right? So some of the, I think most cutting edge surgical trials in the HER2 positive space right now are looking at patients who achieve a breast PCR, and then perhaps we don't need to do any surgical staging of the axilla at all, because we know that in patients, again, with HER2 positive and triple negative, if they've achieved a breast PCR, the likelihood they still have disease in their nodes is about 1%. And so there are 2 ongoing trials right now where the patients are not getting any surgical staging. And so I think adding information like ctDNA on top of our imaging to really help select people who are most likely not going to have any residual disease will help us, again, challenge these paradigms of who really needs surgical staging or who needs breast surgery. I don't really want to put myself out of a job, but my daughter's through college, so it's okay.
Congratulations.
But, again, exceptional responders. We have a little bit of data on this from the MD Anderson group, where they're doing cord needle biopsies to confirm PCR and then just breast radiation. And I certainly don't think that that's necessarily ready for prime time across the board. Right. But it's hard to ignore, again, when we're seeing these rates of PCR in the 85% range, in the ER-negative HER2 positives, it's hard to not think that that's not the future, and ctDNA will likely be a part of making those decisions.
I like those answers. Now, you hinted towards it a little bit. DB11 was 4 of T-DXd first, followed by 4 of TPH. We've seen data last year at ASCO where we had actually impressive PCR rates for just TPH. All right. I've heard other breast specialists, medical oncologists talk about they would have loved to see TPH first and gauge response. What's your opinion on that? And are you thinking of switching the order of these?
Yeah, so really provocative questions, but I think that, really valid though, because our patients ask us these questions all the time. So I think, I tend to be a recipe follower. I love cooking. I usually tend to follow a recipe as much as possible because I know it's time and tested and it's worked. So I think for now, especially as the data is just rolling around, I'm probably going to stick to the recipe. But I do think, adaptive trials may be the future. We've seen data with fair gain, utilizing PET CTs. We have data for breast MRI, maybe ctDNA. So I think we would probably be able to incorporate these different tools that are in our toolbox to be able to have a more adaptive response, even in the neoadjuvant setting, where we may be able to de-escalate for a subgroup of patients and escalate for a subgroup of patients. So really allowing that biology to dictate.
So for now, you would follow the DB11 recipe?
I would be a recipe follower right now.
And I'm assuming going forward, that's your default over the other regimen?
Yes.
I don't want to speak for you.
No, I think that's absolutely right. So in the neoadjuvant setting, I will be preferring, the DB11 approach with 4 cycles of T-DXd followed by 4 cycles of THP.
I work in the community, and both of you guys are you're quasi-academic. How would you consider your practice?
It's an NCI designated center.
So it is academic, exactly. And we know that you are. So there is some data, I don't know how much data there is, but there is some belief that the academic institutions are earlier adopters to new treatment changes and regimens. How do we, as community oncologists, how do we get that word out to the community oncologists that this is very important data and that there's a need to bring this to their patients right now?
Yeah, I think you're absolutely right. I think several of us are comfortable and early adopters because we've participated in the clinical trials and have the ability to sort of use these medications firsthand and also see the impact of them firsthand. I think education around it is really important, but I think it's also important to acknowledge the true concerns that oncologists have. And this could span academic, hybrid, community centers, is really around the monitoring for ILD. So I think we are so used to using T-DXd in the metastatic setting, but this is really a a mindset shift where you're actually thinking about, oh, this is a patient in a curative intent setting. I really have to be tuned in into side effects, and I don't want to trade one problem for another potentially. So I think, acknowledging the risk for ILD, which thankfully was low, and with 4 cycles, about 4% or so, interestingly, slightly lower than the group that received, dose-dense AC.
Yeah. Which was surprising.
Which was really surprising because I don't see as much in my clinical practice with AC, but I think also highlighting the need to use innovative tools like maybe integrated order sets where you could, build in a CAT scan every 6 weeks into your, EMR, so it's easier for you to order and don't have to remember it every time. But it also requires patient buy-in, right? The patients have to come in and be compliant with those visits every 6 weeks for detection. Your team has to be educated. And we don't have a pulmonologist or an ILD clinic per se. We have pulmonologists that are interested, and I'll pick them up and I'll remind them of all the favors that they owe me and to see the patients. But I think having a pulmonologist as a part of the team, that's a true sort of problem across multiple centers, not just community centers. So I think, how can we acknowledge those concerns and try to have innovative solutions towards that, I think will increase the comfort level as well.
Thank you. From a surgical perspective, were you going to comment on that? I do have an.
Well, I think even broader, just the surgical perspective, because it is a team sport, right?
It is.
And I think it's important to, although this data is really exciting and certainly will improve outcomes for a lot of patients. I think we can't ignore the fact that there is a subset of patients that have excellent outcomes with THP alone.
Yes.
And so I really think that the opportunity here is both the escalation and the de-escalation. And I think that for our colleagues that practice in whatever the setting is that you're practicing in, it's really making sure that we're talking about both pieces of that conversation, right? Because a lot of lower risk patients will get a PCR with THP. And certainly, but this certainly now opens the opportunity for us to have be more optimistic about more patients getting a PCR, but I don't think it means that everybody absolutely needs this new regimen. I think we still need to personalize our treatment, risk stratify from a systemic therapy point of view, as well as from a surgical point of view.
So I cannot help but think how the side effects like ILD is going to impact potential delays to surgery. In the study, we didn't see that, but we know that's a sterile environment. In real world, there may be questionable folks getting this regimen. My surgeons definitely want to do cardiac clearance, I feel like, on almost every patient. How are you going to address that? And do you anticipate, or will you try to get cardiac clearance from the primary care or medical oncologist before you take those patients on DB11 to surgery?
I don't think it's necessary as a one-size-fits-all approach. I think, again, everything needs to be considered in the context of the patient's age, their other comorbidities, their history, how well they did on the therapies. Certainly people that struggled through the preoperative course, I may be more worried about than people who flew through without any problem, right? But I think this is where, again, we have to remember that it is a team sport and there has to be conversations. I need to know from my medical oncologist if this patient has had trouble with their therapies or has she not? I need to also, when I'm in the operating room, I need to make sure that my anesthesiologist knows that my patient has received this therapy, just similarly to how I would make sure that they know that my patient received immunotherapy if it was triple negative, right? So just, talking, making sure that everybody understands the situation and making those decisions on an individual basis, I think is what we need to do.
Thank you. Now, I wanted to comment on the ILD in the AC group, which was higher than the T-DXd group. And I think it's because we're looking. We don't normally look.
Absolutely.
You look, you will find.
Yes.
Any comments on that?
No, I think you're spot on that, but I think what was reassuring to me is that, the delay, there was not a lot of delay to surgery. I mean, the proportion of patients in both groups was less than 5%. So I think that I was really reassured by that data as well, that ILD was not necessarily a barrier to patients getting to surgery in both groups.
All right, cool. I think we've we've hammered this enough. Let's go post-surgery.
Yeah, the fun part.
DB05, the fun part. Do you want to give us an introduction to that study?
Sure. So, like you said, DB05 was the adjuvant study. And I think, again, they included patient populations that either had inoperable disease at presentation, or if they had operable disease, they had X-ray positivity or lymph node positivity at the time of surgery. And the goal of the study was the 3-year invasive disease-free survival. That was the primary endpoint. And I think the study did achieve that, with a significant benefit to the group that received T-DXd. So the comparator group is T-DXd, the intervention group is T-DXd, and then the comparator group was T-DM1. Each received 14 cycles per the protocol. And I think that what was really important to think about this study is, obviously the natural comparator in our mind is the Catherine trial, but I think that, DB05 patient population was of a higher risk. And also I think the neoadjuvant regimens were more emulating real-world practice. So, in Catherine, 20% of patients received dual HER2 targeted therapy, but the vast majority, 80% of them received that in DB05. And then the anthracycline use was much higher, over 70% in Catherine, and here it's more like 48, 50%. Again, not necessarily our practice. We tend to lean away from anthracycline therapies, but several centers, especially those around the world, continue to use that. So I think they did a really good job in looking at a clinically relevant patient population, one that we see in clinic all the time, and neoadjuvant regimens that really capture, the population, that the way we treat them. So I think that was really good. The secondary endpoints are, of course, not mature yet. And I think the other, amongst the invasive disease-free survival, we did see a trend towards lower CNS recurrences in the group that received T-DXd compared to T-DM1. And of course, the non-CNS recurrence events were also lower in the group that received T-DXd compared to T-DM1.
So, thank you. What is important is this population for DB05 was a way higher risk population than we'd seen in Catherine.
Absolutely.
But the approval
yes.
does not specify high risk. So it's pretty close to what you would get for Catherine.
Absolutely.
Have you thought about how you're going to use that approach? Which approach you're going to use are you going to re-stratify your patients for a particular approach?
Yeah, I thought you would never ask that hard question. It's true. The label is pretty broad. It says for all patients that have residual disease after, neoadjuvant therapy. And so it does beg the question of, when you have a patient in front of you, how do you do that? Like I mentioned, I'm a recipe follower, so I would tend to follow that recipe. Having said that, again, as Dr. King mentioned, you really have to. It's not one size fits all. Clinical trial does not always inform how you do it in the real world setting, particularly if the label supports that. So if I see that a patient is particularly at high risk and, maybe started off with really high risk features like positive lymph nodes, etc., and have had clearance, at surgery, but still small amounts of residual disease, I would probably, still use that, even though it doesn't strictly meet the same definition. And also I have a conversation with the patient, even if they have small amounts of residual disease, I will let them know that the label does allow you to get it, even if you're lymph node negative or didn't meet the inclusion criteria for the trial. But we have to think about, again, toxicity monitoring, cumulative toxicity for ILD with 14 cycles, and of course the real world tolerance and how many cycles they can get in the real world based on their tolerance.
Thank you. Tari, does the fact that there is a very effective adjuvant therapy for patients who you think has a lot of potentially residual disease, you have that, at least you have an idea going in if you do MRIs. Does that influence your surgery at all?
Well, I don't think that it doesn't make me do less surgery just because I know there's effective adjuvant therapy, right?
Okay,
so I still want to follow, the recipe or the rules from surgical literature about how much surgery I should be doing or how much radiation one should be anticipating, right? So one we certainly know that our treatments are synergistic, they all work together, but not the idea that one should clean up after the other one, right? We all have to do our best based on the evidence that we have. So certainly if I have a patient that has a significant amount of residual disease after preoperative therapy, I'm still going to dissect the axilla until we have randomized data from the Alliance trial telling me that radiation is sufficient to provide local control, right? So I think that, again, it's such an exciting time and it's such an exciting field to be in. That's why we are all here, because we get to think about how all of our treatments fit together for an individual patient. But I still think that we each have to be true to the data within our scope and make sure that we are communicating really well when we're talking about de-escalation outside of what we know to be, demonstrated in trials.
So choose wisely. My surgeons talk about that all the time. How has that influenced your practice?
Yeah.
And then also the guidelines for breast surgeon, I think was it ASCO? You can correct me. Suggest that, really increase the amount of patients that you may not need to go into the axilla. How do you think about that? Can you clarify?
Sure. So yes, so the Choosing Wisely campaign is a lovely campaign that has, has kind of come and gone throughout over the last couple of decades. But in the breast cancer surgery world, the Choosing Wisely recommendation that's gotten the most attention is in older patients with ER-positive, HER2-negative breast cancer who are going to upfront surgery, and suggesting that we don't need to do axillary surgical staging on all of those patients if it will not impact subsequent adjuvant systemic therapy decisions. So a very different population than what we're talking about right now. So this is ER-positive, HER2-negative. If we already know that their systemic treatment is endocrine therapy, if the nodal disease status is not going to change that recommendation, then why do I need to evaluate the lymph nodes? So that was just a recommendation up until the last couple of years, where we now have 3 randomized controlled trials demonstrating that in, again, well-selected patients, largely with ER-positive, HER2-negative disease, with negative axillary ultrasounds, small tumors, grade 1 and 2 disease, no LVI, right, that we can completely omit axillary surgical staging without any increased risk of axillary failure and without any changes in disease-free survival, because you all are making your systemic therapy decisions without the nodes, and patients are still living as long as they're supposed to live. So
you hear that. You just suggested that medical oncology is really curing the axilla.
We're doing a great job.
It's a team sport. I'll keep saying that,
sport.
Right? And so, again, as surgeons, we are happy to de-escalate and to reduce the morbidity, and we may be actually even more willing to do it than you all sometimes. But again, not all patients are the same, not all breast cancer is the same. But certainly, as we think about the different types of breast cancer, and whether someone's appropriate for upfront surgery or neoadjuvant therapy, and then how our decisions impact each other, right? I can't decide to not do the nodes and not make sure that my radiation oncologist is okay with that, right? So there's 3 of us at the table here making these decisions together, of course, with the patient's preferences in mind as well.
Thank you. Back to DB05. Radiation and sequencing. Can you talk a little bit about that? Because it was allowed to be either concurrent or sequencing. Do we see a higher amount of ILD or lung toxicity with sequencing? Because that certainly was a concern.
Yeah, absolutely. And you're spot on in terms of the flexibility in concurrent or sequential. And I don't believe that there was, at least in the data that I've heard, that there was any difference that was noted in the ILD. I do think, just to, get back to the monitoring question, patients did require a low-dose CT scan, at baseline. And then if they were getting adjuvant radiation therapy, it was prior to cycle 3 and 7 and 11. And again, can we somehow automate automate this and have these built into order sets so you don't have to necessarily remember this and risk the patient not getting appropriate screening. I think the other challenge is also, radiation pneumonitis is a real thing. We see that a lot. And so, my team sometimes has challenges in like, for example, in a metastatic setting, if patients are receiving palliative RT and then they're having these symptoms, that is this radiation pneumonitis? Is this pneumonitis related to T-DXd? So I think, again, having the pulmonologist involved as a part of the care team and sort of being able to tease out the differences. But I think regardless, prompt institution of steroids is not a bad idea at all in either case.
We did see 2 deaths, which was related to ILD.
Correct.
On DB05. How is that impacting your conversation with patients or your even decision to use it? And you can chime in also related to the grade 5s.
Yeah, that's obviously unfortunate that there were 2 deaths related to it. I think that, it's just really important to continue to underscore that screening and management, for ILD even more strongly if you're seeing this in a clinical trial population, which is really well curated, carefully followed. I think it does not mute my enthusiasm in using T-DXd, again, because of familiarity and using it in the metastatic setting and being able to, now have education and management strategies as well. It also involves, us educating well the patients about these side effects and promptly bringing it to our attention. As Dr. King mentioned, it is a team sport and a patient is a part of the team. So I think that I will counsel the patients, but I don't think it mutes my enthusiasm.
Yeah, I completely agree. I mean, it is, none of us want to see that outcome with anything that we do. And, but it is part of understanding the drugs, part of understanding how we inform our patients, how we inform our care teams, and making sure that, again, early recognition of any symptom is brought to the team's attention.
All right. So you do, thank you. You do DB11. There is residual disease. What do you give adjuvantly?
You're full of great questions.
I have all of them.
And, the one thing I did want to add to the previous point, too, is patient selection, right?
Yes.
So, in addition to education and monitoring, I think the right patient selection, if they have relatively poor performance status, if you don't expect them to be compliant with, CT scan screenings or have pre-existing ILD or lung problems, I tend to be a little bit careful in selecting those patients. That's the other thing.
Let's talk about that a little bit more.
Yeah.
So in the community, it may become an issue because we may have physicians giving the treatment without doing the monitoring. Is there concern about that? That one, and two, what do we need to do to make sure that appropriate monitoring, appropriate patient selection happens for both studies, but more particularly the one where you get more of the T-DXd drug?
Yeah, so I think there's always a partnership, between community and academic physicians. And I think that I always, encourage my referring community providers that if you have any questions on patients, as selection, et cetera, always reach out to me. I see certain centers have community academic tumor boards, where certain patients are also discussed. But I think education is just so important. And then also, like I mentioned, ways to automate ordering of these, sort of things. So it takes it out of the human control and you have a system that's sort of helping you out as well. And then dissemination of, screening and management algorithms in just allowing them to be a part of the discussion. What are the challenges that you're having and how can sort of those challenges potentially be met? Having relationships with academic pulmonologists, and that understanding that our patients can be referred to you in case they have any problems or side effects promptly. So I think it is a team effort between both community and academic physicians. I think ultimately these are all our patients. So I think we can together participate in making sure that we do our best in protecting from these side effects.
And including the APP team members, right?
Yes.
Because we know that none of us can do this without
Absolutely.
them. And so they really need to also be in that education process, in those conversations. They're the ones that are frequently taking those patient phone calls or getting those messages. And so making sure that they're up to date is critically important.
Absolutely.
And I want to add, as a proponent of community oncologists, we do have some very good community oncology practice who essentially practice academically.
Yeah.
And so when we say community oncology loosely, doesn't necessarily mean everybody. Refer to mainly sort of the generalists who are not up close and looking at the data every day. Just want to clarify that. So back to the topic.
I thought
we didn't
that was a good
it.
way of
Yes. So DB11, residual disease. What are you doing adjuvantly?
So, I mean, I hate to give the answer as a data-free zone, right?
Yeah.
But I think if, again, I follow the recipe of, DB11, I would use TDM1, which the vast majority of patients used. It was specified in the protocol, but not necessarily mandated for use. But I think, the question does come up, can we use T-DXd in the adjuvant setting? If you use T-DXd in the neoadjuvant setting. And I think it's not, I think, out of the realm of possibility. I think I can certainly entertain that. But it really depends on how the patient tolerated it in the neoadjuvant setting, what side effects or challenges they had, but also the amount of residual disease, while they were receiving these therapies. Because I think the way I think about residual disease is that if there are resistant clones and they're resistant to the neoadjuvant therapy or the components of it, and does that indicate biologic resistance to T-DXd? So are we re-challenging with something that the patient is potentially resistant to? And that can be just speculative unless we really have biomarkers to be able to help us understand that patient population that is likely resistant to T-DXd and may not potentially get it in the adjuvant setting. But I do see certain scenarios where I would use it in the adjuvant setting as well.
So the comment to that is, you only got 4 cycles.
Right.
In the adjuvant setting.
Absolutely.
We saw data today, actually, about the length of treatment, the deeper response, or the CR. In order to get a CR, you needed to be, I think, 8.6 months on therapy.
Yep.
These are a lot more cycles than 4 cycles.
Absolutely.
To get a deep PR was 9.6. So it may just be duration of treatment. We didn't give enough, and that's why you didn't get the PCR. I would caution about DB11 and DB05. Again, this is a curative population,
right?
And so we take less risk with that population. And so we see in 14 a lot more tox than we saw in 11. And so if you're adding an additional 4 cycles on top of that 14 cycles,
what's the cumulative
what is the
ILD
cumulative?
risk?
So I would be concerned, much like you, I would go DB11, then Kadcyla, but I certainly would consider it in a patient with significant residual disease. I think of them as locally advanced and probably even sort of in the metastatic realm. And in that,
so you would be tempted to continue.
We would do DB09.
Yeah.
In that realm. And so giving them a little bit extra so as to try to get that cure, I think is not too far-fetched, but that's a minority of population rather than a majority of population. All right. For both of you. 2 studies, DB11, DB05. I'm going to go surgeon first because I think I know the answer. It makes sense. Speaking to your medical oncology partner, and you guys are having a discussion. I have these patients. I want to choose one of them. DB11, DB05. What you're telling him would be your preference?
Well, as a surgeon, again, I always think about it as if my patient's going to get systemic therapy, then there is no disadvantage to using it in the neoadjuvant setting, particularly in the HER2 positive subset, right? So I don't want to lose any opportunity to de-escalate the axilla, for example. So there's no reason for me to vote for adjuvant therapy if somebody needs therapy, right? So I'm very much a proponent, again, of using our modalities in the neoadjuvant setting to try to get that secondary benefit for the surgical outcomes as long as it's medication they need. I would never ask for something to be given in the neoadjuvant setting if they weren't going to get it in the adjuvant setting, right? But, we are definitely, pushing that envelope towards earlier stage disease. Neoadjuvant therapy makes a difference. Again, it helps still monitor response. It still helps us de-escalate. So I'm very much, again, in favor of the neoadjuvant approach, but I still think that, as we said earlier, there needs to be some risk stratification of what they get in the neoadjuvant setting.
I completely agree with Dr. King. I think that, you know, in the patient population that fits the DB11 criteria, the high-risk patient, I would want to offer it upfront, you know, in the manner of the 4 cycles of T-DXd and 4 cycles of THP. I think we learn a lot from whether or not the patients achieve a pathologic complete response or do not. And I think that that information is, you know, can be used to adapt our approach in the adjuvant setting. So when possible, I think I would like to use it in the neoadjuvant setting.
And besides there's almost 20% of patients you could prevent from getting a more toxic regimen in the adjuvant setting.
Absolutely.
If you got them to PCR. So again, that's what I would favor also.
And I think this is it's an important message, because I certainly know when I first entered the field that this idea of neoadjuvant therapy, it was a research question, right? We kept waiting to get to this day where it actually did inform subsequent therapy, where we knew what to do afterwards. And I think that that's an important message to get to the broader community. Not all of us are, you know, not all of our patients or not all of us as providers are fortunate to, you know, just get to focus on breast cancer, just do breast cancer all day. And so the message to get to the broader community of physicians caring for patients is that this is not just a research tool anymore. It's real life now. It's prime time. It help, you know, we know what to do with the information after surgery, and so don't lose the opportunity to help your patient in that way.
All right. I think we've discussed this in great detail. Final words from each of you.
You want to go ahead?
Well, thank you for the opportunity to discuss this with you today. I think both of these approvals are, again, very exciting and a positive step forward for our patients and for our teams. And it's really important that we go home now after ASCO 2026 and really talk with each other about how we're going to choose wisely for our patients. What regimens should they be getting, and how do we make sure that we're all communicating effectively to understand the advantages and disadvantages of these approaches.
Yes.
Yeah, I think that it's a partnership. So, I mean, I feel like now that we have treatments and therapeutic advances, you know, that have really resulted in great outcomes, you know, we continue these partnerships in a multidisciplinary fashion and, you know, not only try to maximize our outcomes, but improve patients' quality of lives and minimize toxicity in this curative setting.
Appreciate it. Thank you.
Yeah, thank you, Greg, for having us.